Good afternoon, everyone, and welcome to today's SVS VQI Registry Revision webinar. My name is Jennifer Correa. I'm the Marketing Manager at the SVS PSO, and I apologize for the delay today. We were having some technical issues behind the scenes. I'm joined today by our presenter, Carolyn Morgan, SVS PSO Director of Clinical Operations, as well as others from SVS PSO and 5OS behind the scenes. Before I turn things over to Carolyn, I do just have a few brief housekeeping items to go over. We will be keeping all lines muted throughout today's presentation, but we do encourage you to type any questions you may have in the Zoom Q&A box. This will allow us the opportunity to answer questions as time allows at the end of today's presentation. If we are not able to answer your question live during today's session, we will reach out to you via email following the webinar. And with that, I will turn things over to you, Carolyn.
Thank you, Jen, and welcome everybody. I hope everybody's having a nice spring so far. Today's registry revision webinar, we're going to talk about a few VQI updates. And then the primary focus of today's webinar will be reviewing the lower extremity amputation major registry revision. And then, of course, afterwards, we'll take questions. So to get us started, I'm going to have Melissa Lattis give us a couple brief overviews about the 2024 PVI source data audit.
Hi, everyone. So we, in 2025, we completed a source data audit on records for PVI cases entered into with the surgery date of 2024. That audit is complete. I've sent out about a third of the results. I'm sending them out as the time goes on. We will do a very high level overview of the results at VQI at BAM, and we learned some very important lessons during that audit, which we will give further information at BAM.
Thank you, Melissa. So with that, we'll just jump right into the lower extremity registry major revision. Just to remind everybody, the amputation registry launched in 2013, and it has not had a major revision since then. We've done some minor tweaks here and there along the way, but it's still in its original format and was never harmonized with some of the more the other registries that have gone through major registry revisions or some of our newer registries. So the purpose of today is the first part of the meeting, I'm going to just go over some screenshots and do some highlights, share rationale for the changes, and then we'll go through and do a live demo. So the first thing I wanted to review with all of you, there aren't very many changes to the inclusion-exclusion criteria for the registry. Prior, you can see at the bottom half of the screen that there is some red text with a line going through it. It was that osteomyelitis patients due to homogeneous spread without ischemia were an exclusion. Now they are an inclusion. You can see that up here and the top red line. Just to note, in case you're not familiar, I'm starting to add dates as to when some of the inclusion-exclusion criteria has changed. We also said that neuropathic tissue loss or osteomyelitis associated with or without ischemia, again, just saying it a different way, was added. And it's any revision on the same side to a higher level performed at a subsequent visit would be recorded both on the follow-up form and then a new amputation procedure form. So the panel here on the top left is just an illustration of what the only registry now that is in its original format, which is the endarterectomy registry. You can see on the blue bar, we had the different tabs of general demographics, history, procedure, and post-op. With this revision to the amputation registry, we moved all of the variables that were in the Legacy General tab and place them into the Demographics tab to align with all the other registries except for CEA. CEA is due for a major registry revision starting later half of this year to be launched in 2027. So this is what your new demographic page will look like in the amputation registry. It's a very busy screen, but when we go through the live demo, it'll look better. I just want to remind people that if you see the blue underscore underneath the variable name, that means that there was a change to the variable, whether it means that there were additional select options or they moved from the general tab into the demographic tab, and sometimes it is just because there was a help text update. For purposes of today, we tried to lay out the form exactly like it is laid out in all of the newer registries. We have functional status, and then we have ambulatory status for our amputation patients. The CAD, your comorbidities, were placed in alphabetical order. But I do want to call out, there is a new variable called depression. The committee felt that it was very important to capture whether or not the patient has been diagnosed and is being treated for depression, and it is simply a no or yes response. The prior cardiovascular repair is newer for these registries. We are trying to keep the history tab solely to include history for the registry variables that is related to. So remove the prior CABG, prior coronary intervention, CEA, CAS, or prior aneurysm repair under the demographics. And again, these are in alphabetical order. We added A1, AB, A1C as a new testing variable. This variable will only show up if the patient has any history of diabetes. And this is just, again, a little bit more detailed view of the prior, or this is, excuse me, this is the history tab now. In the history tab, we ask if the patient had a previous history of a prior bypass, a prior peripheral vascular intervention or PVI, and what is the current amputation side. So for prior bypass, it is just simply any non-cardiac arterial bypass for occlusive disease, yes or no variable, and a prior PVI is simply a prior history of any non-coronary endovascular intervention, including, and I always say not limited to anymore because they're coming out with so many different ways of treating, angioplasty, atherectomy, stent of the native arm, leg, neck, renal, mesenteric. Even though we don't capture those in our registries, this is a legacy variable that the committee still wanted to be able to track PAD and other arterial vessels outside of the lower extremity. Once you decide or select the intended amputation side, we ask, you can see that because we selected bilateral, both right and left show up, and we ask for the indication. Why did the patient have to have the amputation? Did the patient have any history of a prior amputation, a prior endarterectomy, prior inflow bypass, prior inflow PVI, and prior inflow means in the iliac space, and prior outflow is below the inguinal ligament. New to the registry, we added Wi-Fi variables. As you recall, Wi-Fi variables include your ABI. To harmonize with the other lower extremity registries, we included toe pressure and TCPO2. And then we ask for wound or tissue loss and infection degrees. In the procedure tab, we ask for the urgency, urgent, emergent, or elective. The anesthesia variable was changed. We made it multi-select so that if there are multi modes of anesthesia, that we can capture all of those. Legacy variable is your ASA class, but because we moved it from the demographics tab into the procedure tab, that's why it's not underlined in blue. If you recall on the history tab, we said that in this example that it is planned to have both a right and a left amputation, with the indication for right being uncontrolled infection and indication for left being ischemic tissue loss. Those auto-populate within this procedure tab. This is new. We ask at the end of the amputation procedure, what was the status of the incision? Was it left open, for instance, a guillotine, or was it closed? If it was closed, we ask for the dressing type, and if there was an adjunct vacuum-assisted closure. And then if the incision was left open, we ask, is this a planned staged amputation? In the post-op tab, historically, or in the legacy registry, we asked for the total number of any transfusions from admission to discharge. And with this major revision, the committee only would like to collect the total number of transfused units of packed red blood cells within 72 hours after the amputation. Another change to the registry is for change in renal function. The select options used to be none, creatinine that has increased greater than or equal to 0.5, new temporary dialysis, or new permanent dialysis. We have since retired the variable of increase in creatinine, and instead now are asking for what was the highest creatinine before discharge. In the post-op tab, we ask for a number of they're the same variables, they're just laid out a little bit differently. When we talk about a planned return to the OR, if you abstract yes, we ask, was it for interval debridement? Was it for an amputation to a higher level? Was it for closure or formalization? And if you say yes, what was the date? If there was an unplanned return to the OR, if you say no, you don't have to answer any of the questions. But if you say yes, we ask, was it for bleeding, infection, or progressive disease? And then as the final question, we ask, what was the highest final level of amputation? In addition to the registry, we are collecting some discharge opioids. We just want to know what the patient was discharged on, what opioid or non-opioid medication the patient was discharged. No dosing is asked, no frequency is asked, just the name of the post-op opioid. One final change to the post-op, it was important to capture why the patient didn't receive the antibiotic. So we say, did the patient, if you say no to they did not receive the first or second cephalosporin, we say, did the patient receive alternate antibiotic therapy? And if you say yes, then we'll ask for the reason why. There was already a documented infection and the patient was on antibiotic therapy already. In the post-op tab, we have some additional variables, I wanted to call out that we put the discharge or the long-term follow-up medications in alphabetical order, and we renamed the prior P2Y12s or P2Y12 medication label to antiplatelet meds or drugs to align with all of the other registries. And for at time of long-term follow-up, we do ask one opioid question. Is the patient still taking opioids with a no, yes, or unknown response option? One thing new to the registry for the long-term follow-up is there is a classification system similar to task class classification. It is called K-levels. K-levels is a Medicare functional classification system on a scale of 0 to 4 that is used to determine an amputee's functional mobility and potential, helping to guide the selection for appropriate prosthetic components. So K0 means that the patient doesn't have any ability or potential to ambulate or transfer safely with a prosthesis. K1 means that the patient's ability to use a prosthesis for transfer or walking is typically limited to just indoors or inside. K2 means that and these are still very ambiguous, but I had to stay with the definitions provided by Medicare. K2 is that they have the ability to do some low-level environmental barriers like stairs or uneven surfaces. K4, they have the ability to walk various speeds and navigate most environmental barriers and engage in vocational or high-level exercise. And K5 are for those young folks that unfortunately had an event, but they were able to get a prosthesis and they can run marathons or they can continue being an athlete. This is just a visual for the different K levels. I will eventually be putting together a handout on this, but we will eventually include this visual within the help text so that if someone wants to just print it out, they'll be able to have it at their fingertips. For the long-term follow-up, we do ask for the K level. And then because this patient in this example with the screenshots had bilateral amputations, we ask if they received their prosthesis. We ask about residual pain. In the legacy registry, we used to ask about phantom pain or residual pain. Now it is all combined into one because it's hard to differentiate. Patients interpret residual pain or phantom pain differently. Is the patient experiencing any joint contractures? This is a legacy variable, but it's underlined in blue because we added help text. Does the patient have any neuromas? Did the patient require a reoperation on the amputated limb? And if so, was it required for a non-healing incision? If you say yes, we ask the reason. Or if they required a reoperation on the amputated limb after the healed incision, if you say yes, we ask for the same type of select options. Was it primary infection? Was it ischemia? Or did the patient experience dehiscence or trauma to the amputated limb? From the time of discharge to the long-term follow-up, did the patient require amputation to a higher level? If you say yes, we ask what was the higher level and the date. And with that, I'm going to pull my screen over and we're going to do a live demo. So this is what your lower extremity amputation registry demographics landing page will look like. As you recall, if there is a red asterisk, that means that this These variables need to be completed before you can save the procedure. Primary insurance was, the help text was updated. We have your functional status. If you click on your functional status, you will get your help text. And if you want to see your revision history, this was just because it was updated to be harmonized with the other registries. You have your CAD variables, your dialysis variables, and again, we harmonized this with the other registries just to know functioning transplant or currently on dialysis. Your depression variables, no or yes. With your help text, what I would like to call out is a formal diagnosis of depression in the electronic medical record is encouraged for variable abstraction of yes. Documentation of a patient using antidepressant medication for data abstraction of yes is not advised. If there is no formal diagnosis of depression in the electronic medical record, it is recommended to consult with your healthcare provider for clarification.
Carolyn, we just have a question in the chat. Sorry, I for whatever reason, Zoom was not letting me come off of mute, so I apologize. What is the rationale behind adding depression to this registry? Is it just a wellness check? Are we considering the use of medications that may affect hemodynamics? They're just curious.
It's a wellness check. It is they without evidence-based data, they believe that there's a correlation between depression and how well our amputation patients progress or continue on with recovery.
Thank you.
So under your prior cardiovascular, again, we moved these from the prior history tab over into the demographics tab. If for diabetes, you say none, no A1C shows up. If you say diet or anything beyond, we request an A1C level. And same thing with your diabetes variable. If you say that the patient is on dialysis, creatinine is not asked. Again, we renamed your P2Y12s to antiplatelets, and we ordered the pre-op medications in alphabetical order. Moving on to the history tab, we ask about previous bypass. Again, we showed these in the screenshots. Previous PVI. And what is the current planned side for amputation? For purposes of today, I'm just going to say it's the right side. The indication for the amputation is uncontrolled infection for our demo purposes. The patient does not have a history of prior amputation. And if you say, if they do, we ask what was the level of the prior amputation? No yes response for prior endarterectomy. Your prior inflow refers to a prior bypass graft that originates above the groin and typically ends in the groin, such as an aortofem, aortobifem, axfem, or iliofem bypasses. Your prior PVI, same thing. It is endovascular repair, for the aorta, common external iliac. Your prior leg bypass are your bypasses from typically the inguinal ligament down. So it could be a fem-pop, fem-tib, fem-pedal, pop-tib, perineal tib, any type of combination. And then your prior PVI are your PVI procedures, including but not limited to balloon angioplasty, stent graft, atherectomy, IVL, etc., that originate from the common femoral all the way down into the foot. These are your Wi-Fi variables. So your pre-op ABI, we ask for a value to put in, but if you say not measured, it will gray out and you will get credit for answering the question. You can answer not measured for any of these. I just want to make sure that people know that toe pressure and ABI are different, and your TCPO2 is usually obtained at the dorsum of the foot, below the knee, above the knee, and there is typically a range for your PCO2 of 0 to 150. We have some folks that are trying to report TCPO2s in the 400s. I have never seen that unless a TCPO2 is being measured while the patient is in a hyperbaric pressure chamber. And eventually we will update the TCPO2 to say that measurements done during hyperbaric treatment are not to be included. We ask about tissue loss. Was it a small ulcer, deep ulcer, or extensive ulcer? And we provide help text for that. And then the infection, mild, moderate, or severe, with the different definitions in alignment with the Wi-Fi published document. Moving on to the procedure tab, we have our elective, urgent, and emergent urgency variables. Those are legacy variables with newer help texts that were updated within the last 2 to 3 years. Your anesthesia can be multi-select. We ask for ASA class. And now we get into the current amputation side. The right side and the uncontrolled infection, auto-populated from what was selected in the history tab. We ask about the incision, if it was closed, what kind of dressing was placed. Was it, and these were collapsed a little bit. These used to be there used to be a lot more select options so that they were collapsed. Is it a rigid dressing? Is it immediate post-op prosthesis, or it is an other? Your rigid includes your rigid and semi-rigid with examples of paste dressings, air splints, removable and non-removable dressings such as casts. Your immediate post-op prosthesis is a prosthesis that is applied immediately post-operatively, and all of your other gauze dressings, with or without, or sterile dressings, would be captured in the other category. Was there a vacuum-assisted closure? Yes or no? We don't need any details of the type, but just yes or no.
So Carolyn, we have 2 questions on this. Both are if the incision is left open, are you able to, if your incision is left open and they just put on a vacuum-assisted closure, how do you document that?
We'll review that in just a minute. I'm going to go through and change this to open, and we'll go through the same process.
Perfect. Thank you.
And were there any thoughts on a planned staged amputation? Just yes or no, and then the estimated blood loss. So if the incision is opened, we ask if it was a planned staged amputation. No, the patient did not have a planned staged amputation, or the patient needed to have a planned staged amputation with an eventual closed incision. So this is all focused around whether the incision was left open or not. If it is left open, the committee did not feel it was important to capture whether or not there were wound vacs placed. In the post-op tab, we ask for the discharge date and the discharge status. What is the discharge ambulation? The number of transfused units within 72 hours after amputation. We ask about post-op complications. Again, the change in renal function. We removed the increase in creatinine of 0.15. And then we added what was the highest creatinine prior to discharge. This patient had a open incision. So was there a planned return to the OR? Yes. Was it for an interval debridement? Meaning they knew that they were going to have to go back and debride and clean up the wound until it was at a stage where it could be closed. Were there any amputations to a higher level? Just no or yes? If you say yes, what was the date of the amputation to the higher level? And what was the date? Did the patient return to the OR for closure or formalization? This might sound like an odd question, but the reason why we put it in here, unfortunately, there's some of our patients that are so sick, they die before their guillotine amputation was ever closed. And the committee felt that it was important to capture yes or no for this. Did the patient have any unplanned return to the OR? Unplanned return to the OR includes variables for bleeding, infection, or progressive ischemia. If the patient had an unplanned return to the OR to have their gallbladder removed, we are not collecting that as related to the amputation procedure itself. So if you say yes, we ask, was it for bleeding, infection, or progressive ischemia? And what was the highest final level of amputation at the time of discharge?
Carolyn,
Again,
oh, sorry, go ahead.
no, go ahead.
No, there's a question that I'm skipping for now until we finish this section, and I'll go back to it. But then there's a second question. Is if there is more than one return to the OR for additional amps, is there any direction on which one should be entered?
It's the last, the final.
Thank you.
If there are additional intervals, let's say they do all 5 toes, then they'd have to do hindfoot, and then they ultimately end up with the BK. I would put the middle amputation of the hindfoot in the comments section. This is our discharge medication. You can select, multi-select. And then for non-opioids. For your pre-op antibiotics, if you say no, then you were asked, was there alternate antibiotic received? You can say no, and then you'll be done. But if you say yes, why did they receive alternate antibiotic? Was it because they had an allergy to cephalosporin? There was already a documented infection and they were already on antibiotic therapy that was working. Or you didn't know, it's not documented anywhere, or there was another reason documented. So now I'm going to close out of this and I'm going to go into the amputation long-term follow-up. And I didn't say my normal disclosure that this is all demo data. There is nothing, no real live data here. So this is what your lower extremity long-term follow-up record will look like. We ask for the date of contact, face-to-face. These are all harmonized variables across all of our registries. What is the patient's current smoking status? Again, we ordered our current medications in alphabetical order and renamed the P2Y12s to antiplatelet to harmonize across the registries. And we just ask a yes or no variable or unknown if the patient is continuing to take opioids. We ask about the K level and provide the definition for K level. Did the patient receive a prosthesis? Yes. Is the patient still having residual pain? So residual pain includes stump pain, phantom pain, painful sensations such as burning, shooting, stabbing, any type of pain is the patient experiencing. Does the patient have any joint contractures causing soft tissue tightness that could limit the joint motion? Neuroma, with the definition of what neuroma is, and a yes/no response. During the long-term follow-up, we encourage documentation. Did the patient require any reoperation on the amputated limb? And if you say yes, we will ask, was it required for a non-healing incision? If you say no, no more questions are asked. If you say yes, the reoperation was for a non-healing incision. The incision at the amputation site just wouldn't heal, wouldn't close. What was the indication? Was it a primary infection, ischemia, dehiscence or trauma, or other? If the patient required, I'm going to say now, this is no. But if the patient required a reoperation on the amputated limb after the incision healed, was it because they had a primary infection, ischemia, dehiscence, or trauma? They hit their, oh, that would hurt, their amputated site and it opened up the incision, or other. Was there required amputation to a higher level? No or yes? If you say yes, you are asked what level. And then the last or most current amputation to a higher date. So if you had multiple amputations to a higher level, it is at the time of this long-term follow-up visit, what was the last highest level of amputation along with the date? And with that, now we'll proceed on, Melissa, with questions.
So to go back to the main record where I asked you about if they have multiple levels, which one do you enter? And you said the last one. It's not the level they're asking about, it's what date do you put in? The date of the first amputation or the last?
The last.
And then if the amp level changes during the principal procedure, which level do you select?
It was the amp level at the time the patient left the operating room.
And I think that is all the questions we have. We'll wait and see for a minute if we get a couple more.
You know, I think the committee does its very best to anticipate what may or may not come with data abstraction. Whenever we go through a major revision like this, I always anticipate there might be a couple tweaks along the line or along the way that we might have to tweak the registry a little bit. So if you have any questions or suggestions, you can send them over to Five-O's. Five-O's will share them with me, and then I'll take it to the committee to get their feedback. We always appreciate people's feedback. The committee was extremely thoughtful, trying to not add too many variables because that's registry burden, registry overload, but at the same time, collect enough data to make the registry meaningful.
And we have one more question or comment. Can a copy of these new forms be sent to the MDs?
We typically don't send the forms to the MDs. This registry will be released to production May 21st. If the physician wants a form, they can either ask the data manager to send them a form, or they can log into Pathways and get the form themselves. I don't have the forms quite yet. They haven't been fully developed yet. I was asked to provide the education well in advance of release so that people could prepare. I did send off the data dictionary to all of the data managers that are enrolled in the registry. So if the data managers would like to share the data dictionary with the physicians that they know that are doing these types of procedures. See, the slippery slope you get into is you have we have a user list, and our user list includes every physician for every registry that the center is enrolled in. So for instance, you might have interventional radiologists or cardiologists that are doing PVI or carotid procedures, to just go to this list and send a data dictionary or a form to every physician listed within your pathway center. I think I'd probably get beat up.
On top of which, I'm sure doctors' emails get very full. I think people are hesitant nowadays to open emails with attachments that they're not anticipating. So I think oftentimes when we send things out, I don't know that they always get looked at and opened.
What else can I help you guys with? I hope this was helpful. Again, I apologize about the delay in getting started. I think we got through a lot of good, meaningful information. We'll be doing a little bit more education on the K level at VQI at VAM. Dr. Abu Zamzam, who is the chair of the Lower Extremity Amputation Registry, will be attending VQI at VAM. So if you have any specific questions about why or rationale as to why some of these changes went into place, or if you have more questions about K level and understanding that, Dr. Abu Zamzam will be there live to answer your questions. Well, with that, I thank you all. I am looking forward to seeing many of you next month, and happy soon Memorial Day.